Hello and welcome to the Health Tech Marketing Show. I'm Adam Chirinas. I'm your host, and I'm the CEO and founder of Health Launchpad, my marketing consultancy that specializes in healthcare technology. My co-sponsor for the show is HIMSS, who've been a partner of ours pretty much since the beginning of this whole thing, this whole shenanigans that we've been having with the show. And I'm very grateful to them for their support. And I'm also very grateful to you for listening. If this is the first time you're listening to a show, you can subscribe on Apple or Spotify or whatever your favorite podcast app is. And there's also a YouTube video of this so you can see what we look like. Now, I'm going to bring my guest to the stage in a second, but first of all, I want to talk a little bit about what today's show is about. So anybody who's been subscribing to our stuff for a bit will have seen that we do quite a lot about how buyers buy. And we recently did a whole episode about the healthcare IT buying process, which is some really terrific new research from HIMSS, where they got feedback from close to 100 healthcare IT buyers. And we presented that with a couple of CMOs who joined us in the panel to present that. And it was a really great session. I strongly recommend you go back and look at it. And I was recently talking to a new connection who I'll introduce shortly, JD Whitlock. And he's a CIO of a healthcare system. And we were talking about what we were learning from this. And we thought, well, wouldn't it be great to actually hear from somebody who's a real healthcare buyer and hear what it's like from his side of the fence to buy any type of technology, what the process looks like, shed some light on some of the insights that came out of that research. Also, it's an opportunity to hear the pet peeves, things that you really don't want to do if you want to build a relationship with folks like JD. So let me introduce JD Whitlock. JD, welcome to the show. I'm so glad you could join us today. Please.
Thank you. Happy to be here.
Please tell us about yourself. I think you've got a really interesting background.
So I've been in healthcare for almost 30 years now, and starting out as a healthcare administrator, not on the IT side. So I'm not a purebred geek. I'm a healthcare administrator that became a little bit of a geek over time.
Yep.
And so I've got a real heart for value-based care, population health management. I got a background in public health. Is how I really got started in healthcare. And I am retired military. So I did military healthcare. I am, of course, military, along with the BA, been doing value-based care before it was cool. Right. So I had a pretty good background in that. And that informs a lot of what I do. In some previous roles before my current role as CIO at Dayton Children's, I was more focused on data and analytics and value-based care stuff. Well, so for the last 6 years, I've been blessed and privileged to be the Chief Information Officer at Dayton Children's, a wonderful health system that I'm just continually amazed at how we actually are walking the talk of doing the right thing for the patient as it's supposed to be a nonprofit healthcare, right? Sometimes it is, sometimes it isn't a nonprofit healthcare. Yeah, and the way that the leadership makes decisions about things that really are in the best interest of our patients. So a couple other things about Dayton Children's. We are on the small end of Epic customers. So a revenue in the 600 million range. And that impacts some of what we're going to talk about today in our 5 minutes. But I've also, my previous employer, Mercy Health, now Bon Secours Mercy Health, sort of the opposite end of the spectrum. Huge, massive health system, multi-state with, when I was there, it was 23 hospitals. Now they're up to 50 hospitals with the Bon Secours merger. So I've seen both sides, what that all looks like. We could talk about that a little bit also. So
I always think, it always amazes me. I've now been in healthcare for close to 15 years. So relatively short term compared to a lot of people in healthcare. But it always amazes me as well. We're a relatively small organization. We're only 600 million.
Right.
And I think that people coming from outside of healthcare, it's eye-opening to understand the scale of organizations. So I want to talk about the topic of how organizations like yours buy technology. And I think what we'd probably do is actually kind of refer back to some of the things that came out of the research. So one of the first things that came out of it was that the complexity of buying is just increasing. It's not getting any easier. And in particular, it was I think it referenced that more than a quarter of the organization said that there are at least 10 people involved in the buying process. And I think for more than 2/3, maybe it was 2/3, it's at least 5. And so I'm curious about, from your perspective, what the typical group looks like. How do they form? How does the stakeholder management process work?
Sure. So first of all, when we talk about all these people that are involved in the buying process, it's very important to distinguish between two concepts. Concept one are the decision makers. We are going to buy or not buy this new thing.
Yeah.
Concept number two is we have decided to buy this new thing. Now we have a process, and we have lawyers, and we have supply chain directors, and we have other people that were typically not necessarily involved in the yes or no, but in the how.
Yep.
And cybersecurity reviews and all these other things that really have to happen. They're still sort of in the buying process because these people all get involved before the before the signature goes on the contract, right? But typically, from a sales and marketing perspective, you're mostly interested in who are the people that have to say yes to make this sale, right? Some of those other people, cybersecurity review, the red lines on the master service agreement, those are potential veto things, right? But 98% of the time, if you're having those conversations, you're going to get to those things and make a sale, right? So let's talk about the first part, which is the who's making the decision, right? So in most organizations these days, you don't have individual people making decisions, particularly on the larger purchases. It's some type of a committee, and what it ought to be is broad operational leadership that are buying into this new thing that you're going to do. And so that's how we do it at Dayton Children. We have an IT governance committee. I don't share it in the sense that it's ultimately the voting members. It's basically our executive team minus our CEO. And there, when it comes down on the rare occasions we have actually controversial things, or this is a good thing, but we just don't know if we should spend this money on it. And it's sort of close in the voting. Those are, I can think of, in my 6 years, I can think of maybe a handful of times we've had to make those really, really hard decisions, right? And most of the time it's getting buy-in on some new thing that we want to do. I am aware that many health systems don't have mature governance processes, and they still have people doing cowboy things and going and buying things and then coming to IT and say, I bought this new software package, or I bought this new medical device. Now you IT need to figure it out and get it plugged in, even if it doesn't match with the architecture at all, even if it's a poor choice. And so we recently did an application rationalization exercise with a consultant. The consultant did not come in just to do that. They came in to do sort of overall efficiency stuff, but along with it was an application rationalization. And they were very complimentary and said, oh, you don't have we didn't come up with very much, of things you could potentially get rid of. And I joke with them. I say, well, if you just don't let people buy things in the beginning, then you don't have to turn things off.
It's quite unusual that.
Yeah, exactly. But here's the part I don't understand. I don't understand why senior leadership lets people buy things. Just because you have a budget doesn't mean you ought to be able to just go buy IT things that don't fit in with the architecture. That's actually not how it should work, right?
Being on the seller side. So when I ran a software company, I founded a software company in 2012 and ran that for about 7 or 8 years. And I would find that we found that there were two types of sale. There was the IT-led sale, which was very much the way that you described it. It was never, sometimes the need would initiate in IT, sometimes it would have a clinical need, but the process would be structured and managed and disciplined and managed by IT. In other cases, it would be a clinical-led sale, and sometimes it would be structured, sometimes it would be a little bit of a free-for-all. And I always felt that those were organizations where maybe that the the medical staff was was put on a pedestal, and they kind of had license to get away with, to a certain extent, whatever they wanted. Mm-hmm. I don't know I think that's probably more the dying breed. From us as an organization, it helped that, I'm reasonably technical. My partner was a physician. So he took those sales and I took the IT-led sales. But going back to your governance, so where would a need initiate? Would that typically within IT, or does that initiate somewhere else?
So I think Adam, you just described it very well. You're going to continue to have both of those scenarios. So it just depends what it is. There are some things that I get very involved with very early. So for example, everybody's looking at ambient AI clinical documentation, right? Yeah. Super deep integration with the EHR, or at least should be, right? And let's make sure we pick the right one. It's really complex. How are we going to, providers are going to use it, have to have some skin in the game. That is something that I would think naturally that CIO is going to be very involved with. And when I do we have collaboration calls, we have, Epic CIO collaboration call, we have Children's Hospital Association CIO call, where this is what we talk about. One of the hot topics, not the only hot topic, obviously. So that's an example of that. An example on the other side would be, the clinical department X wants to buy a new point of care ultrasound device. I care in making sure that device is going to be able to play nicely with our enterprise imaging initiative and get into our vendor neutral archive, because not all imaging modalities can do that, and not all imaging modality vendors play nicely with that. I say, you want to put that image in your archive? Now you need to buy more software to do that. No. That's not how we want to buy things in 2024. So that would be an example of something that's totally clinical led. We just need to do some IT common sense gate checks on things. If you're selling something that is something cardiology, well, your primary decision maker is still going to be the chief of cardiology, right?
Right.
Or in large systems that can get complicated. So.
And I think that the companies, for anybody listening to this, they've probably figured out that. Let's talk about the buying cycle. For me, it's still the single biggest difference, I think, between healthcare and any other industry is how long it takes to make a decision. And I think the research showed that buying life cycle was a minimum of 13 months on average. Is that what you experienced? And why is that?
Yeah, so obviously nobody sets out and says we are going to have a 13-month buying cycle. That's not That's not how it works. What does typically happen, though, is it's very important for sales and marketing people to understand just the budget cycle for whoever you're trying to sell to, right? So typically, for larger purchases, it needs to be budgeted for. You don't just have a pot of money sitting around waiting for that next innovative thing to come in. You're going to have to make the case during the budgeting process. So Dayton Children, we start a fiscal in July. That means that next month, the budget's going, which means that about now, the time of year, we're actually getting things ready to go, putting things in the hopper for the budget request. So actually, just so happens right now is a good time for incoming cool new things. If the incoming cool new thing comes in April after we've done the budgeting, you may have to wait till the next go around. And obviously, it depends on the cost. That is not true for truly smaller purchases. The nice thing about, so for example, some software as a service products can be sold relatively inexpensively. I'm always amazed at sometimes how expensive some of the software as a service products are that probably shouldn't be as expensive as they are. But, the amount of governance, the amount of discipline that needs to go into things is also related to the cost, obviously.
So let's just go back to you. You gave the example of ambient AI. So I'm going to assume that could be, for an organization like yours, could be a 7-figure purchase potentially. And I'm assuming that it would then be on the sort of, given the complexity of it, kind of on the long end of the purchase cycle. That true? Was that not a good example?
I'm sorry, in the long end?
Yeah. So like something like ambient. I mean, so Take me through the process for an organization like yours to buy ambient AI.
Sure. So I have worked with talking to other CIO colleagues, some of the early adopters, obviously talking to vendors, talking to the gentleman at Class Research that tracks this, talking to our Gartner healthcare analysts, all those typical people we look at to get smart at this, develop a short list, and then do demos. We did demos. We recorded the demos. We obviously want to get providers to see the demos, and you can obviously never get all the providers that want to see it together at the same time. So you do the demo with a handful of providers. These demos happen to be fun because the way that the vendors demonstrate having the best ambient node is to just get actors from the health system to role play an encounter and ham it up and make it complex and see if the software can handle that. So they're actually really fun demos to do. So a little bit different than your normal thing. I mentioned earlier about how part of the decision process here is how are we going to, providers are going to have some skin in the game in this, right? And so how are we going to do chargeback? What does that all look like? I have heard some innovative health systems do things like based on efficiency, provider efficiencies. If you realize some of the efficiencies that are supposed to come with this technology, you're going to have less or no payback, right? But if you don't, then there may need to be some kind of chargeback to your clinical department. So people are trying to figure all this out right now. And because it's so new and because it's so hot, there is, you asked me where I found it. LinkedIn is just, I curate my LinkedIn feed with a lot of smart people. And so I hear from CMIOs and CIOs. Obviously, CMIOs are super interested in this. And, we tried this. Here's our lessons learned. Some of the first journal articles are starting to come out on this. I was talking to a physician at one of the vendors we were looking at who was picking apart one of the first journal articles from a methodological perspective. And so these are all the kind of things we're looking at.
So this was so in the upfront part, when you're doing the research around this, talking to peers, talking to analysts, but also you're curating influencers on LinkedIn and looking what they're doing. Very interesting. Okay, so then you get the demos, there's a lot of theater involved, but that's kind of cool. Then, so would this be something that you're putting in the budget for next year, or was it in the budget this year for last year for this year?
Definitely the former, yeah. So we're talking about what that looks like putting in the budget. You mentioned 7 figures. It shouldn't be 7 figures for us.
Oh,
more, okay. Hopefully than five figures. Now, here's the other thing. You do not assume that all of your providers are going to use that. It's going to be, who knows, if you get maybe 50%. Yep. Some providers just get so good at either the speech to text, the Dragon Medical Online, or the 3M equivalent. They're so comfortable with that they don't want to try something new. My wife's a nurse practitioner. She does sleep medicine. She does intake for sleep medicine. So you get a referral to sleep medicine. She gets your sleep study ordered and gets all your history. She is just such a good typist that she does everything in the visit. Now, these are obviously not the most complicated specialty encounters we're talking about, right? Sleep medicine intake. But nevertheless, she would never use anything like that just because she's got her system down and she would really benefit from it. But the point is, even if only 50% of providers want to use it and use it, the value proposition is pretty compelling for those who do want to use it. And that's what some of the early results are saying. So
there's a piece of research that was done by one of the marketing technology vendors. Very interesting bit of research. And it said that most buyers, when they buy, it's business to business buyers, so technology in particular, don't reach out to a vendor until they're 70% of the way through their process. Does that make sense to you?
I wouldn't agree with 70%, but I agree it doesn't start at 0%.
Right. Yeah.
Yeah. You typically do some research, and often we'll try to do some kind of a down select first.
The other thing, which was that came out of this research, which just blows my mind, if it's true, is that 84% of buyers report that they end up going with the first vendor they call. And that's not because they're, just easily influenced by the first vendor. It's because they kind of decided who they're going with.
Right.
So I'm just curious, as like when you're going through a process, have you picked typically before? I mean, and that's not a criticism.
No. So back to the down select, right? So if there's 10 vendors in a space, you're not going to do full blown research of everybody. You got to get down to 3 or 4, and then now I do understand why that might happen some of the time. If you're looking at a particular category, you're looking at the class score, for example. We all pay attention to best in class. That means something. Yep. And so, and if you have a handful of vendors on class with good reviews, and we don't just see the score, we also see all the comments that all the other customers have put in, right? And then sometimes those other vendors just don't fit. They don't do the whatever version of just doesn't have a good Epic integration or something, right? And so then actually you can pretty quickly winnow things down to maybe you always want to have at least 2 because you want to plan together for cost, right? So
right. Yeah.
Sometimes we know what we want and we add some others just for the negotiation purposes. That's true.
Right. Okay. All right. So yeah, not quite as drastic as that other research reported, but in some cases you've certainly got, you've got a pretty clear sense of who the shortlists are, and you may have a lean towards one over another. Okay, let's talk about, you've hinted at sort of things that you use during the research process. What types of content and information do you want to see from the vendor, and in what form?
Yes. So this is perhaps one of the most important things, and I see so many people doing this wrong. Think of the old marketing elevator speech concepts.
Yeah.
Right? Hone it down, hone your value proposition down to something that can fit into a LinkedIn introduction, that can be the first few sentences of an email that you sent, because that's about as far as we're reading. If you don't catch, if you start out with a relationship, if there's no relationship there and you start out wanting to have a relationship, you just missed your opportunity to hook with the value prop. So now I also have to be careful here. I may not be typical of all the buyers, right? So we just talked about you're also selling to clinical leaders.
Yep.
Right? Clinical leaders, many of them self-selected into the healing arts because they are very relationship-driven people with big hearts.
Yeah.
I'm a cynical analyst type. Just give me the facts. Right.
Right.
So that's my approach. It's not necessarily true for everybody, but I am amazed by, obviously, I guess I shouldn't be too amazed. The people that self-selected the marketing and sales roles are often relationship-driven, right?
Yeah.
They're reaching out. And I know you do some work with account-based marketing, and I understand what that is. That's important because if your total market size is just a few hundred health systems, you have to think like that. But I always get a chuckle when people reach out and they say, as a cold open, they say, I'm on your account team. No business relationship whatsoever. I'm on your account team. We don't have an account team. I've never.
Right. Yeah.
I'm open with
congratulations for you, right? Yeah.
Congratulations for you. Open with what your value prop is. Understand. So the other thing is, obviously do your homework, right?
Yeah.
But understand what our platform is.
Right.
We're an Epic shop, or a Workday shop, or a Microsoft shop, or a Sectra for our enterprise image. If you're selling something that's going to plug into one of those things, like open with that. And here's how we're adding value on top of your platform. Don't try to sell me something that's already in my platform. That's a complete waste of time.
That's very clear and very helpful. So that would manifest itself on the website, in email, on LinkedIn, all of those channels, right?
Absolutely.
Absolutely. Yep. Got to be crystal clear.
Yeah.
And, just kind of thinking about the factors that go into deciding whether a company's going to make the cut or not. If you go to their website, what's your kind of mental checklist of the things that you want to see? Yeah.
Sure. So I've had this conversation once. I've had it 100 times with it. So we're in Epic. You go, oh yeah, we integrate with Epic. What's the first thing I'm going to do, Adam? I'm going to go to the Epic Connection Hub, or whatever Epic is calling their app store this week, because I like to change the name, but today it's the Connection Hub. And I'm going to see if it's on there, right? Mm-hmm. And a lot of times it's not. And then what they meant by they integrate with Epic is 3 years ago, they did some custom HL7 something. That's not what I mean by that. We've all been burned by products that demoed well, the cost was right, and we said yes, and then it took a year to get something integrated because the vendors integration team didn't really know what they were doing, or even if they did, the complexity of this custom app, custom interface was just, we spent more effort doing that, so more resources and the effort building the interface than we paid for the software, right?
Right.
That's vitally important. Yep. We live in an API world here, right? And understanding the APIs and leveraging the APIs of the platform vendors you're trying to integrate with, that's both a challenge and it's also an incredible opportunity, because it means you can take products that previously the level of effort for the integration, the level of effort to get the data in and out was too high.
Yep.
And now if you're using the APIs correctly, that level of effort just went a lot lower. That might very well mean that that cool idea you had is now commercializable where it wasn't commercializable before.
Right.
So there's an incredible opportunity there. But yeah, you got to know how to sell that. You got to know once you are talking to the IT folks, you really got to what's wrong with the interface stuff.
So I have this debate with some of our clients, which is the amount of information to put on the website. So some say, no, it's got to be really short and simple, straight to the point, and we'll have a few bullet points, but not that much detail. I think there's a counterpoint, which is if we're in service of folks like you and your colleagues in helping them do their research, structure the information so that they can find their way through it fast, but give them a lot of depth. Let them go really deep if they want to.
Sure. Yeah. Well, there's this concept on the webpage. It's called the hyperlink. You can link to more.
I've heard of that. Yeah.
So first of all, speaking of websites, explainer videos.
Oh, yeah.
We've all been to websites, some business to business, healthcare, doesn't matter. You're trying to sell something that's relatively complex. 1 minute explainer video of what it is you're selling. Back to the elevator speech concept.
Yep.
Because if you do reach out on LinkedIn and I'm interested enough to click on your profile, then I'm interested enough to click on your company and go to your website, and you've got a really good 1 minute explainer video. That's really powerful.
Yep.
And then, of course, you're also going to have some high level verbiage of what that is. But then you at the bottom of the page, you say, and click here if you want the full data spec APIs we're using.
Right.
Whatever. It's easy to do, I would say.
Yeah, exactly. As you say, there's the thing called a hyperlink. Yeah. We talked a little bit about value props. So I remember this. Early on in our life of my own software company, we were able to demonstrate an ROI. We actually sat down with the CFO of one of our hospitals, this Jersey City Medical Center, now part of our WJ Barnabas. And the CFO was such a supportive guy, and he spent a couple of hours with us breaking down where our application was making an impact. And we got it down to a really clear ROI, and we're able to sort of show our math in getting that. However, every time we get into a sales pitch, she said, okay, where's the ROI? So we showed the ROI, said, yeah, I don't believe that. And I think that a lot of companies have the same challenge, which is we want to show you the ROI, but how do I actually get you to believe that it's not just marketing, it's actually true?
Sure. So you mentioned a conversation with a CFO, right? That's probably where you're going to end up.
Yeah.
Right? Because the clinical champion you're trying to get interested in the beginning wants to hear those letters, ROI, that, oh yeah, there's more ROI, there's more chance I'm going to get a yes to this, right? but they're probably not going to be the ones diving into that. So in the same sense that as you go down the sales pipeline path, and you're going to have to talk to the cyber team about HIPAA compliance for storing PHI in your cloud.
Yeah.
You got to talk to the legal team about redlining the MSA. Yeah, you may have to talk to the CFO or somebody in the finance team about justifying the ROI figures that you've come up with. But you always want to start out with that. Absolutely. Of course, the best thing you can do for ROI is you can have it in a case study, and it says these are not theoretical ROI numbers.
Yeah.
These are specific ROI numbers that our other happy customer that you can go talk to will back up that this is real ROI numbers. That's obviously the best way to sell that. By the way, we all, CIOs are all tight. All I need to know is what health system you're talking to. I'm probably already connected to them.
Right.
If not, except my LinkedIn.
You're one hop away from it.
One hop away, and I can say, hey, can you put me in touch with whoever your Bubba is for the software, whether you're happy with it or not. That happens all the time. It's funny. Vendors are like, well, I don't know if they want us to give you your contact information. I don't need it. I just need to know who's if you say they're a happy customer, I call them and they're not a happy customer, that's a problem.
Right. Yeah, absolutely. Yeah, you're kind of toast. What are your trusted sources? I think you talked a little bit about that earlier, but I'm just kind of curious to get you to expand a bit on that.
Yeah, sure. So number one, class research. Now, full disclosure, I'm on the class advisory board.
Okay.
That is not a paid position. I'm not pipping them because I'm getting any money from them. But most health system CIOs pay a lot of attention to class research. Now, you know the line, if the online service is free, you're the product, right? So the product is my reviews on your software.
Yes. Absolutely.
And I hear from vendors, class is pay to play. Well, yes, it's pay to play. That's the business model. They get the reviews from system customers, and then they do a really nice job presenting all that data in ways that are very useful to both vendors and buyers, right? And somebody's got to pay for that, and the model is vendors pay for that. But I guess what I say to people that complain about being pay to play is like, look, if you want to tap into this industry that's a fifth of the GDP, you might have to pony up a little bit of money to get onto the consumer reports of healthcare software.
I think it's very interesting, that, JD. I think there are, I'm familiar with 3 analyst firms. So Class work very closely with them, with my company. Gartner work very closely. And then there's another one, which I was less familiar with, but I actually got to know them recently, Chillmark.
Chillmark, yeah. I'm also on Chillmark Advisory Board.
Oh, okay. So John Moore was actually on our podcast a couple of weeks ago.
I listened to that podcast. Yeah, John's a great guy. I really work with him. A little bit different model, though, than Class. I think fewer people probably heard of Chillmark, but they go really deep on certain topics. Yeah. And so it's really sort of a different model than the Class.
I think it is.
Gartner's also important. Gartner, of course, I'm paying for Gartner.
Yeah.
And it's expensive. But if you use it appropriately and do all the analyst calls, ultimately it pays for itself because you're doing cost avoidance on not making dumb decisions. All across your architecture, whether it's just the pure IT stuff, not specifically clinical stuff. Mm-hmm. If somebody's not familiar with Gartner, I don't know how many analysts are up to, a couple thousand analysts who wake up in the morning and spend their entire day on some really narrow piece of IT something infrastructure software. And so you get the handful of those analysts that are specific on healthcare are also they're just super smart. When we were doing we were picking a PACS and VNA vendor a couple of years ago. I worked with one of the Gartner analysts on a RFP template and getting all the latest and greatest, not just on what was going on with the vendors, but where was enterprise imaging going? Right? Yeah. So yes, all of that. That's all of the things are.
What are some of the other sources? You mentioned LinkedIn, but what about HIMSS Media, right?
Sure.
Histor, all those guys. What are those?
Absolutely. Trade press in general is talk, all that. I subscribe to lots of those things. And then on a super busy day, I'm I may not even open the email. If it's not a super busy day, I scroll and I maybe read one of the most interesting headline and I skim the article, but I'd rather subscribe to more of those. And then, if I start seeing the same topic in multiple of those, that must be more.
There's something going on. Right. Yeah. And what about events? I mean, do you go to HIMSS? Do you go to Chime?
Yeah.
Do you go to Vive?
I've gone to HIMSS except for obviously pandemic when it happened.
Yeah,
I've been going for 20 years to HIMSS. It's funny. Some senior IT folks will say, I don't like HIMSS, there's too many vendors. Well, that's a feature, not a bug. I mean, that's where all your vendors are. So you go and you can walk the show floor and talk to the CEO of the company that you don't normally get to talk to. You normally talk to your account exec, right?
Yeah.
And have in-depth meetings with the more strategic vendors and walk the part of the floor that's they do the little tiny, what do they call them? The emerging technology, or how they do
the pavilions. Yeah. Right.
Yeah. And sure, I just walk around. I make myself a list of vendor booths to go to in order of the booth number.
Yep.
So I can go through in order. And that's a big now. And also the education sessions are very good at HIMSS because they do a very good job screening them and coaching people.
Yes.
I've been through that. I've presented at HIMSS a few times. I've been through that process a few times. They do a very good job. So often I'm, there's like 3 sessions I want to go to at the same time. And I also need to go hit the show floor. So HIMSS is very valuable. It's unfortunate that Vive has turned into sort of like this competitive thing with HIMSS. I don't know how many CIOs can go to both.
Yeah.
There's the travel dollars to go to both. I did go to Vive last year because I was able to drive instead of fly.
Yeah.
Nashville and the Children's Hospital CIOs were getting together there. So I've experienced it's a well put together show. But it's funny, a lot of the vendors like, well, you're going to Vive too, right? Well, no, I'm not. I can't go to both.
No, I can imagine. So this has been interesting. I want to close with a kind of a punch list of dumb things vendors do that just annoy you, your pet peeves, and then maybe close with vendors that get it right. What do they do well?
Yeah, sure thing. So okay. So some dumb things that vendors do. So number one is spend lots of money on a booth at HIMSS, and then when I'm walking by and I'm reading the booth, I can't even tell what they do. Like the people that designed that, the meme, you had one job.
Yeah.
One job, which was to explain what your company not, with very few exceptions, maybe Epic.
Yeah.
Most vendors should make it very clear what the heck it is that you do when people are walking by your booth. So that's one thing. Let's see. Oh, we already talked about, hey, I'm on your account team before there's any relationship. Voicemails, it's 2024. Nobody listens to this. It's completely wasted. I mean, by the way, it takes a lot more effort to do individual voicemails, Oh, here's one. Spoofed local area codes.
Oh, yeah.
It's becoming increasingly common. Now, listen, I have to answer that. If I get a call from local area, I've got to answer it. It could be one of our providers that's in line with something that needs to escalate something. It happens rarely, but it happens. And so when it's a vendor and they start telling me about stuff, I say, hold on, where are you calling from? And they say something, states away. And I go, you're calling me from a local area code. Oh, I don't know anything about that. That's just how the phone system works. And I say, do you think it's a good way to start out a business relationship by lying about something as simple as where you're located? And then I say, I realize you didn't make that decision, but pass that up the chain of command. That's not a good business marketing.
That's a constructive and a much nicer answer than many people would give.
Yeah. Sometimes it's not that nice, but I watered it down for podcast purposes. See, back to the value prop. So if you are staffing or us or IT services or us, if you do everything, you do nothing. I mean, I get probably one a day from staffing companies in software development, IT services companies. You might as well really not bother. We typically have our staffing partners already that are really good. And we pretty much only do that for niche epic things. If we're implementing a new module, once again, paying attention to the class ratings and everybody else's experience with that vendor. I don't know if you're with a startup staffing vendor. I don't know how you start off besides existing personal relationships. That I have sympathy for you, but don't have time to talk to you. Speaking of not having time to talk to you, a really dumb opening line is, can we schedule some time so we can better understand your challenges? Has that ever worked? Once. I can't imagine that.
It used to work in the 90s.
It did in the 90s?
Yeah, it was a sales technique in the 90s. It was called consultative selling.
Yeah, once again, elevator speech. I'm either interested in your value prop or not. Here's another one, starting emails with graphics. We've all got our filters on to protect malware from coming through.
Right.
And so we don't see the graphic. We just see a white spot with a little red X thing in it, and we just hit delete.
Right. Yeah, and it usually blocks out most of the screen.
Right, exactly. That's where your 3-sentence value prop should be instead of the graphic, right? Let's see, what else? Don't badmouth our platform vendors.
Yeah.
Most Epic customers are pretty happy with Epic.
Yeah.
We're happy with our major platform vendors. We're not switching off of them.
Yeah.
So understand that and talk about how you work with them and add value to them. So those are those things. I think we have, in terms of the good things to do, I actually think we already talked about that.
I think you did. I think you've done a really good job. JD, this has been a masterclass in how to market and sell to someone like yourself and sell to an organization in a way which builds partnership and builds trust. And I really thank you for being so candid and eloquent. And also want to thank you for your service. You mentioned that you're in the military healthcare, and thank you for that. So
yes, retired military. I get a check every month, so thanks for paying your taxes.
Good, you're right. I'll keep doing that. One more reason to pay my taxes.
That's right.
So with that, I'm going to say thank you, and I'm going to wrap things up. And so thank you to you for listening. Thank you again to HIMSS for your support. And again, subscribe to the show. So if you're watching us on YouTube, click the subscribe button. If you're listening to us, and it's the first time you're ever listening to one of our show, do subscribe to it. We've got so much more stuff coming out, and there's a big library of other episodes that if you're in marketing, in healthcare, technology, it will help you with your job. And that's our mission here. So with that, I will bid you adieu.